Okay, thank you, Dr. Ryan. Thank you. Now to the chronic AC joint dislocation. Now, what about AC joint, not joint? And this is important for humanity and not only for human body. And this is all can join to stop genocide. Thank you, Dr. Ghassan, thank you, Dr. Anas, and thank you for all colleagues in the world who work their effort to stop this genocide. And thanks for our colleagues from Palestine, Dr. Qawasmi and Dr. Abarra, and others who came from West Bank and Jerusalem and spent a lot of hours to reach us. Thank you. Now, what about the AC joint, chronic? The patient has questions. Should I do the operation? What happens if I keep it like this? And what is the risk if I have surgery? So, and if the patient read more about the subject, he may tell you, please doctor, I don't like to have this or this, clavicle fracture or coracoid fracture. And we have always answered that if the patient needs surgery, we have some tips to avoid that, but this is still a risk, as Dr. Abu Talib said. And there are other risks of surgery, like loss of reduction, which is very common, and also the patient may have persistent symptoms like hardware irritation, residual instability, infection, and stiffness. So the question, how common are these? I think this was mentioned. This is very common, and this is a systematic review with the persistent pain due to hardware irritation or loss of reduction was on the top of these complications. So why to do it? What happens if I leave it like this? Now, we know to answer this, we have to know I think we have learned from yesterday that the scapula is moving in 3 planes, not in 1 plane. And also there is a rotational motion. I think with this, not mentioned maybe, rotational motion of the scapula on the axis of the clavicle. So we need vertical, horizontal, and rotational stability. And Dr. Bassem told us yesterday about the effect of chronic AC joint dislocation on the scapular motion. Now, this chronic dislocation will change the orientation of the scapula and leads to kinematic alteration. And this may lead to chronic symptoms like pain, weakness, fatigue, instability, scapular dyskinesis, or what we call the sick scapula, where there's dyskinesis with malposition of the scapula. So what about the clinical data? How much these affect the result of conservative treatment so that we can answer the patient should do surgery or not? To answer this, we have to go back to the classification. And there is agreement that type 1 and 2 for conservative, high grade 4, 5, 6 for the surgical treatment, but the debate is on type 2. Now, type 3, sorry, yes. And we, like we heard from Dr. Raed, type 3A and P, and we check P that indicate a horizontal instability, and we can check that by cross body adduction view. Now, this may lead to significant instability, the horizontal instability, and this may be indication for surgery, so there is still valid option for conservative treatment. But surgery indicated in persistent symptoms and in high-grade injuries or those high-demand patients. Now, these all studies and systematic review showed very good result of conservative treatment, excellent functional outcome in more than 80% of cases, with faster recovery, lower complication rate compared to surgical treatment, and also with similar pain level at 6 months. But the problem is persistent bump, which usually does not affect the patient's symptoms or functional outcome. So, what's about if conservative treatment fails? This is important. Does delaying surgical treatment increase the risk of fixation failure or major complication? Now, by all the studies, all techniques, yes, the complications are much higher when you are delaying the surgery. But now, when you use the modern fixation, suspensory fixation device, the functional outcome are comparable. And the same, if you do combined AC reconstruction, AC ligament reconstruction with CC ligament reconstruction, the results also are comparable. So don't worry if you treat your patient conservative, and this is a call for conservative treatment. So if you treat him conservative and the conservative treatment fail, don't worry about delaying the surgery. Now, what about the surgical options? We know that acute within 3 weeks, after that either subacute or chronic. And it's accepted that after 3 weeks, the ligament lack its potential for healing. And this is maybe the need for tendon graft, and this is a question, do we need tendon graft in chronic cases? The answer is yes. By systematic reviews comparing different treatment techniques, it showed that using a graft will improve the functional outcome. And the other question is whether to do anatomic or non-anatomic reconstruction of the CC ligament. Does this matter? And to answer this, we have to review the anatomy, the functions of the CC ligament, because as Abu Talib said, it's not only vertical stability, this provides horizontal stability, especially the conoid ligament. So this is an example of anatomic reconstruction using tunnels and screws. And what happens if you do it in this configuration, non-anatomic? The answer, here's a biomechanical study showing that if you do it in the anatomic configuration, that on the left, this will provide significantly higher horizontal stability. So always anatomical is the best. Now, this is another example or an example of non-anatomic reconstruction of the CC ligament. And you see here the ligament is wrapped around one strand in the tunnel and other around the posterior clavicle. But here the surgeon used the suspensory device. And this is the other question. Do we need suspensory devices or fixation, primary fixation when doing reconstruction? Because this expected to provide mechanical stability till integration of the graft, and this may lead to fewer recurrent subluxation, lesser residual pain, and may lead to a better functional outcome. Now look to this. In this study, the reconstruction is anatomic. It looks excellent using tunnel and screws, but on follow-up, the loss of reduction was reported in 100% of cases. While in this study, he used exactly the same technique, but added the suspensory device, and there was much reduction in the rate of loss of reduction. So in this systematic review, they showed that the best functional outcome is when you do anatomical reconstruction with the use of both mechanical, synthetic, and biological enhancement or augmentation. Now the last question, do we need to do AC reconstruction? The answer again is yes. AC ligament reconstruction and repair, especially in high-grade dislocation, this will provide a significant higher stability in the horizontal plane. Now, what about the technique of AC ligament reconstruction? Because we know we need rotational, not only horizontal stability. And this is a biomechanical study showing that when you use the wrapping technique, what we call wrapping suturing technique around the AC joint, it provides a much higher stability, and the least was for the transacromial technique that we thought before that this may be the best way of reconstruction. So to have a best outcome, you need anatomical reconstruction of the CC ligament using a tendon graft, internal bracing, suspensory devices, and to do AC reconstruction maybe and repair of the deltopectoral fascia. Now, is this safe? No, we have always risk. When we're doing anatomic reconstruction, this means that we use tunnels, and there's always a risk of fracture by using these tunnels. So what to do, what modification, because most of these related to the tunnel and sometimes maybe technical errors. What to do, to avoid fracture of the coracoid, you can do this modification that you put the graft subcoracoid, you loop it around the coracoid without making tunnels. And for the clavicle, we should avoid multiple drill entry, we should avoid wide tunnels, and also when you put tunnels should be small and in the center of the bone, not on the edge. And what about the use of interference screw? Because this acts as a stress riser. So when I do reconstruction using tunnels, I don't use interference screws. Now, this is another modification to avoid clavicle fracture by wrapping the graft around the clavicle without making a tunnel, and augment this with suspensory fixation device using only minimal small tunnels for passing of the suture. And actually this is what I do, and I like to do. I don't like tunnels in the clavicle. We go arthroscopic subacromial, prepare the undersurface of the coracoid, and then put the primary fixation, but I don't do tensioning till finishing the procedure. And I use this. This is very nice trick. Use the cannulated switching rod, so we can pass a tunnel anterior and posterior to the clavicle and pass the nitinol wire within this switching rod. So this is very nice trick, help you on this type of technique. Then we pass the graft around the coracoid, and after passing the graft, we continue by wrapping technique around the clavicle, and I use the wrapping suturing technique around the ACJ. So, take-home message: the rule is for conservative treatment, operative treatment when indicated, and especially for those patients with persistent symptoms, and we can improve the stability and functional outcome by using a tendon graft, using suspensory fixation device, and combined AC ligament capsule repair or reconstruction. And you have to do your best to avoid clavicle and coracoid fracture, especially when making tunnels. Thank you.